Looks like we're getting people from across Canada. This is wonderful. Great to see all these locations here. Welcome. And I believe we'll get started now as we're on the hour and start with our welcome.
Yeah, thank you, Alice. Well, hello and bonjour. A very warm welcome to each and every one of you for joining us today at the KDE Hub for this very special webinar on what is a very blustery day in Waterloo. We had a major storm join us about an hour ago. So I am Colleen McMillan, and my colleague and co-scientific director is Alice Schmidt-Handich. And we are here as members of the KDE Hub located at Renison University College in Waterloo, Ontario. I'm now going to hand it over to Alice, who will do the land acknowledgement for us. Alice?
Great, thanks everyone for joining us today with Dr. Nancy Poole for our presentation titled Applying a Trauma-Informed Approach in Mental Health Promotion. While we're meeting today on a virtual platform, I'd like to take a moment to acknowledge the importance of the lands which we each call home. You may be located in various parts of the country, and feel free to post your location in the chat. With gratitude, we acknowledge that Renison University is located on the traditional territory of the Anishinaabe, Haudenosaunee, and Attawandaron peoples, which is situated on the Haldimand Tract. This land was granted to 6 nations and includes 10 kilometers on each side of the Grand River from mouth to source. Our active work towards reconciliation takes place in all corners of our campus through research, learning, teaching, community building, and outreach. We're guided by the work of our Reconciliation and Restoring Steering Committee and Anti-Racism and Decolonization Spokes Council, as well as the University of Waterloo's Office of Indigenous Relations. We're grateful to be part of Renison and the University of Waterloo, and we celebrate and share institutional commitments and learning towards decolonization and reconciliation. So we have a few information items to share before we introduce our featured speaker. And first off, we're going to post a poll. And the poll for the poll question is, through which affiliation did you join this webinar? So if you can tell us a little, or click one of the options for your connection with the KDE Hub, that would be appreciated. And we'll leave the poll open for a few moments to leave time to respond. And I'll share a few information items to note for this webinar. So for those in our audience today who are French speaking, please be aware that the simultaneous interpretation into French is available for this webinar. You can switch to and from English and French channels using the interpretation button on your Zoom controls. So in addition, the materials from this webinar, so there will be some presentation slides. You also received some information, links and handouts prior or along with your invitation, and they'll be provided in French following the webinar. Also, please note that this webinar is being recorded today for future viewing. And also, if you have questions, and we hope you will, during Dr. Poole's presentation, please post your questions in the chat, as there will be a 10-minute question period with Dr. Poole beginning approximately at 2:45. And along with those web links and handouts that will be shared. So finally, thanks everyone for participating in our poll, and we appreciate your input. And over to you, Colleen, to introduce Dr. Nancy Poole for us.
Thank you, Alice. It is such a pleasure to introduce our speaker for this webinar, Dr. Nancy Poole. And let me take just a few moments to share a few opening remarks about Dr. Poole. So Dr. Women's Health, a research center in Vancouver, and she is also the prevention lead for the CAN FASD Research Network. She is a national leader in trauma-informed practice and has co-developed toolkits and training curricula on trauma-informed practice with agencies and governments right across Canada, and is committed to improving action on the links between women's experiences of violence. She has a doctorate in education and was recently awarded a Doctor of Laws honoris causa by the Justice Institute of BC in recognition of her many, many contributions to women's health, including trauma-informed practice and the treatment of substance use and addiction. This very brief introduction hardly does justice to Dr. Poole's impactful work on addressing the many impacts of trauma on individuals, communities, and systems. So for the next 40 minutes, Dr. Poole will share with us her wealth of knowledge on the relationship between trauma and mental health promotion. And on that note, I will hand over the webinar to you, Dr. Poole.
That's so great. Thank you so much for the introduction. And I'm so excited to see so many people from across the country today. Really looking forward to having the chance to hear your questions and to share a bit about what I know with you all. I just want to check that my screen is up correctly. Can somebody, it is?
Yes, it is, Dr. Poole.
Okay.
See your cover slide. Thank you.
That's great. And just before I begin, I'll just add to the land acknowledgement from my location. I'd just like to acknowledge with respect that I'm calling in today from the traditional territory of the Lekwungen speaking peoples and the Songhees, the Esquimalt, and Wasanic peoples whose historical relationships with the land continue to this day. So I will just start by just acknowledging how popular trauma-informed approaches are and how they're being adopted and adapted by many types of systems of care. And, you know, I think that's such a neat thing to think about it in relationship to mental health promotion. I've been busy over the past decade or so working with all these different systems of care, building training and thinking and action on trauma-informed practice. And I'll talk a bit about some of them through the way that are relevant to your work. But I think it's just really important for us all to see this as a very clear movement and paradigm that is really important for us all to take up. So I'm going to just really briefly talk about trauma and trauma-informed practice before I go into the organizational level work that I promise to cover today. But I think one of the most exciting and interesting things for me is that it really comes from and is honored by, and foundational material comes from all these theoretical perspectives and research work that's happened over the last decades. And, you know, I've been somebody really involved in the violence against women work and their contributions around the importance of establishing safety before you carry on with whatever else your work is about. And then, of course, the work from Indigenous scholars and community-based knowledge keepers on the impact of colonization, and I'll talk a bit more about that. But even more, their work around strengths-based and resilience-oriented approaches, and really seeing things not from the place of deficits, but from the place of strengths and resilience has really contributed to this work. The work of some public health researchers in the US on the long-term impact of adverse childhood experiences, I'm sure many of you have heard about, is another whole area of contribution about how in later life we see chronic health conditions that can be directly linked back to early traumatic experiences. And finally, you know, most recently for us all has been this learnings that come actually from neurobiology. So you can see it's a really diverse circle. And I think that's its strength, that we're pulling from really strong traditions as we're doing this work. So, you know, there's a lot of different definitions of trauma, and I think it's a really overused word, but just wanted to, you know, indicate it as, you know, based in an event or series of event or set of circumstances that's experienced by someone as very harmful or threatening, that has lasting adverse effects. So it's, you know, it's quite a big thing. It's not the event itself, it's the way we experience it and the way it affects us in the long run. Now, the neurobiologists have really helped us understand it from the point of view of the fight, flight, freeze reaction that is, you know, often happens at the time of the event. But I think, you know, that third bullet point there also really helps us understand it from that relational perspective, that it really can result from forced uprooting and dislocation from family, community, heritage, or culture. So it's a very complex term and is, I think, really a key part of doing trauma-informed practice is understanding the depth of it. I've given some examples of them, you know, on the left side there, and we're increasingly seeing trauma that is caused from natural events like wildfire and flood and tornadoes. But, you know, we've more traditionally seen it as caused by people and through all these various types of violence and invasion and terrorism and all manner of bad acts. I mentioned that it can be developmental, that it can be really something that is a series of events or circumstances that are experienced early on in life that have late long-term effects. And, you know, that it's not just an individual experience, it's so often really a group, community, or mass experience as well. So a lot to think about then, so what does that mean for all of us? Before I go on to that, I do just want to acknowledge, you know, the importance of a trauma-informed practice needing to include how colonization has worked cumulatively to create complex trauma for Indigenous people. And I've included, or I've given to the folks at the KDE Hub a list of resources, including the ones on this page, to send out to you afterwards. And all the things I mentioned will be, you know, in a list for you to be able to go deeper later if these things are particularly relevant for your practice. But I think, you know, what's important for us to understand is a paradigm shift to see trauma as often central to all these other concerns. And this was something we in the women's movement created 2 decades ago, this idea that women's experience of substance use problems and mental depression and other mental ill health conditions and their experience of violence against women all had at their core this, you know, experience of trauma, and that if we treated substance use separately as a disease and looked at it as something that meant you stopped using substances only, that was not actually going to get to the nub of it. And of course, all the determinants of health, the more distal ones being really important too. So this is what we're facing, I think, in our work now, is this need to understand the responses people can have to trauma, to recognize that that has implications for how they relate to us in mental health promotion services and others. And that we really need to think about the resilience and the support of the workforce that are working with people with trauma day to day. And so that's a lot of what we'll talk about in the second half of this. But just quickly again just to describe trauma, you know, what we're dealing with as we work in trauma-informed approaches is both in the moment responses that people may have this, you know, that are re-triggered in the moment, but also these really long-term responses for trauma. And if people have been reading people like Gabor Mate and others, of really how it becomes part of our health, our sense of self, and so many parts of our lives. And maybe that's why we didn't recognize trauma as so central, as an important thing for us to be dealing with, because it does overlap with so many conditions and so many health and social and spiritual concerns. So lots to think about as we start to think about what does it mean in terms of taking a trauma-informed approach. And I'm sorry if this is a dash through things. Hopefully many of you have been exposed to this before. I teach, you know, whole days on trauma and trauma-informed practice, and you're getting it, you know, the 5-minute version, but here we go. So the trauma-informed practice thing, I think, is a really important thing for us to think about. It means that we integrate an understanding of people's past and current experiences of violence and trauma into all aspects of what we offer, whether that's a service or a prevention or health promotion option. Whatever we're doing, we need to integrate this understanding in, and that we do that to avoid re-traumatizing people and to really bring in these ideas and choice and control and health and healing. So it's not a treatment, it's not a technique, it's not a flavor of the month. It is a deeply important way of working. And I like that SAMHSA, in one of their early documents here, talked on the cover that trauma-informed care is as much about social justice as it is about healing. And I think that's really captures the breadth of it and the importance of it for us. And, you know, lots of Indigenous thinkers in Canada have really added in what it means specifically for Indigenous folks. But I think Suzanne Matteau here really captures this idea of understanding the connection between an individual's life experiences and the impacts of trauma on that, and how we then need to recognize this in the way we interact. So here's the way we've been thinking about it to take such an enormous concept and important response and make it doable, is to think about these 4 principles as really helping us apply trauma-informed approaches. So first of all, it is, you know, taking time to be aware of the prevalence and the impacts of trauma and the ways that people have adapted to cope with it, both positive and negative. And I think that's that's what you're doing today, and that's a really important piece of it. The other principles about creating safety and trustworthiness, you can see how important that is if people have been overwhelmed by bad experiences, it is really reparative to think about, the importance of starting with, creating a trustworthy relationship when that may not have been their experience. And it means for everybody in all different ways. When I'm thinking about the work on fetal alcohol spectrum disorder, I'm saying to service providers, so when you're trying to help women not use alcohol in pregnancy, don't start the conversation with how many drinks do you drink a week kind of thing, but start with a relational practice of, what you already know about alcohol in pregnancy, and start a relationship with it where they can see that you want to hear their perspective as well as provide advice about what the science says. So really creating, an extra layer of relational practice up front is really important. And also reparative is that idea of, listening for what they may feel able to do and having some control over their choices around it. And I'm going to spend most time on the fourth one because I think it's most closely related to mental health promotion practice, about how do we help people develop particular skills for managing their self-regulation type skills and coping skills and empowerment orientation. So it's a lot to think about, but I guess, really important for us all to recognize in it is that this is a universal approach based on these principles. It's not about trying to find the people who've had trauma and get them talking about it. It is not about case seeking for trauma. If anything, as I say here, it's about case seeking for resilience. It's for us to think about how do we create our organizations and what we offer to the people, the service users we work with, that is universal, because we understand that the vast majority of people will have had some experience of trauma, and therefore, how do we bring this work in? And like I said, I think, if we just take one of these principles as an example, I think, the one around building strengths and skills is a really relevant one to your work, that, supporting people to think about what might work for them in terms of grounding and self-calming skills. And there's lots of, work being done to share ideas about what are some of those. And I love the ones from Lisa Najavitz, the Seeking Safety one. She's got like 82 ideas for safe coping skills on one of her handout sheets, and really gives people the sense that, it's going to be up to you to figure out what helps you, but there's a lot to try and find strength in. I just added this in as something to give you a sense that often we can't really make our settings completely trauma-free or re-traumatizing, I guess, in the way they're set up. And this was a case where some folks thought about how can we be trauma-informed in correctional care? And they came up with this idea of bringing a trauma-informed approach, the safety, the choice, the connection, the strengths and skills, et cetera, in using the peace approach, where they really spend time saying, this is a place where it's hard, that often things are really not trauma-informed. So predicting that there will be challenges and preparing people. And that can happen in a conversation about mental health promotion too, is saying, let's talk about where you think you know, what you find helpful when you're stressed, and, you know, please, let's, you know, is it getting up and walking around, or is it counting to 10, or whatever that's helpful to you, and we'll just stop and make sure we do that if that comes up for you in the conversation. So just making it normal that people will want to put in practices that are helpful to them, enlisting their ideas, acknowledging their strengths, giving choice within the parameters of what you can do, and then explaining a course that meets the parameters of your organization and their needs. So really, you know, lots of people have thought through what this means for them. And here's an example of something we did with the BC government not too long ago around how can we bring trauma-informed practice into the way we respond to the opioid crisis. How do we do it within, you know, engagement in the service level? How do we really build skills and pain management skills in the people we see? And how can we help the service providers who are providing care to people who have trauma experiences and are overdosing, etc.? So really lots to think about in terms of how we bring it in. Just, you know, don't have time to you know, time to how important it is that we think about trauma-informed in the circle with other really important lenses we're bringing and practices we're bringing to our work. And I do think there's so much about trauma-informed practice that is in alignment with culturally safe approaches, and where the First Nations Health Authority says about being curious and respectful partners rather than figures of higher authority. And the work, lots of interesting work being done around thinking about racism and how racial equity is really important to be advancing, even as we're doing trauma-informed approaches. And I've done a lot of work also with others around how are we gender responsive, even as we're doing trauma-informed approaches. And this is from a chapter in a book I edited about being trauma-informed, about what trauma-informed might mean if we think about masculine norms for relating, and how might trauma-informed practice look different with boys and men based on that, you know, that traditional norms that you know still persist in society about men as, you know, not able to talk about their feelings, and really not able to see themselves or resolve, as Sheldon Kennedy has said, that conflict between their identity of men and their experience of powerlessness. And so how do we respond to that? So lots to think about around how we integrate all these things. And, you know, really encourage you to think about in your organization, spending time having some discussion about what are we already doing well in relation to these principles, and what else, what's the stretch from here? Because it is really something that needs to be worked on at the organizational level. So I'm going to slow down a bit more and talk about the work at the organizational level for the next 15 minutes or so. And just want to acknowledge that these principles of trauma-informed practice are really important to enact at both the organizational level and in interactions with service users. And these folks from the Equip Health team, some of the nurses at UBC, Colleen Varco and others, have really done a great job in this quick sheet talking about the 4 principles and what does it look like in terms of organizational policies and procedures, and what does it mean in terms of individual interactions. I think they do a really nice job of it. And I've included the link to that in the handout that you'll get, the list of links. But I like this image from Trauma Transformed, which is from a group in California that has an amazing website. And I think they give us a nice picture of what it means to be trauma informed. That, it's that centerpiece where we think about clients, staff, and caregivers, and our leadership in terms of resilience and recovery, in terms of collaboration, in terms of trustworthiness and safety, in terms of cultural humility and equity, etc. And that we really shift our practice to take these ideas together. And that we're not expected to be the whole-on healing organizations, but I think we really need to think about who in our communities are doing the healing work, so that as we're offering mental health promotion ideas, that those people who need more than what we offer around to cope with histories of trauma, and also get connected to the people who are more at the therapeutic and healing level. But really important for us to think about this center thing. What are we doing with our clients, as I've just talked about? But even more, I'm going to spend some time thinking now about the blue and gray levels of how, as an organization, are we altering practice at the level of us as staff or workers and as leadership. I just want to mention an experience I had not too long ago with the YWCA Toronto. And they undertook a project also with Public Health Agency of Canada funding, as the KDE hub has, to think about what they could do as an organization towards being trauma informed. And I just think it's kind of interesting how they went about it. First of all, they did assessments at all their sites using the 4 principles sheet, which was, what are we already doing well at enacting these 4 principles, and what's the stretch? And they have like 12,000 women and girls, that are come to their services over the year in 35 sites. So it was a big thing to think about where each site was at and where they wanted to go. And then they co-created some training materials, and they involved participants in the programs in creating what we called the Powering Up workbook, which was them thinking about how they could contribute to helping the organization be trauma informed by having some support and direction themselves. They involved leadership in doing quality improvement, and they did all kinds of multi-level, multi-involvement over time. So I just wanted to signal that I think, every organization will come at being trauma-informed differently, but there's lots of ways of beginning and continuing and thinking through. I just wanted to offer one more example about how, other organizations have thought it through. And this group in the US thought about a trauma-informed child welfare system by really thinking about these elements along the bottom. And I just wanted to emphasize the blue one here, the enhance the well-being and resilience of those working in the system. And I think they were among these folks were among the first to recognize that child welfare systems have to have well-being and resilience of children and families. But the workers, those three groups are really important, not just the client and the support systems for clients. So I thought it was just a nice visual of where, what may be important. So I created this sort of summary of what the work looks like at the organizational level, or could look like at the organizational level. I adapted it from this document called Key Ingredients for Successful Trauma-Informed Care Implementation that was by a healthcare system. But this was for, some folks who were trying to be trauma-informed when they were working with methamphetamine users in various provinces in Canada. So, but I think these 8 things are places where all organizations can think about their work and enhancing their work on being trauma-informed. I'm just going to talk about 2 of them on this list, but I think there's hopefully lots of inspiration here. I wanted to talk a little bit about the worker wellness side of trauma-informed practice, and really how people who are delivering care aren't going to, or interventions of any kind, not necessarily formal care, need to think about they have to be healthy themselves, and they also likely have trauma histories they're bringing to the table. So really thinking about balancing, how do we support worker wellness? And you've probably heard a lot about self-care, which is really important, but also it shouldn't fall only on the individual worker to find self-care that works for them, although it's key. We need to think about these other 2 levels, the middle one being about how do we promote dialogue and democracy and thoughtfulness about trauma-informed practice through debriefing exercises that are not about critical incident debriefing only, although you'll all likely do that as well, but to really think about these kinds of reflections as an organization about how are we enacting these principles? What are we learning from times where we notice that we could have been more trauma-informed in our work? And what is, what did we learn from that? What did we do well? What do we need to do organizationally to prevent, re-traumatization of that ilk again, kind of thing. So the more these obstetricians come up with 5 questions for debriefing that are really kind of neat, that are just really appreciative inquiry type questions that I think can be really helpful. But recognizing that in the research, a lot of protective factors for burnout and vicarious trauma, etc., are these things like feeling like you are a team working together and being able to see change as a result of your work. Not only seeing trauma, but seeing people finding paths forward and seeing your organization as improving in its ability to be trauma-informed. So I think it's really neat to see that we're thinking about organizational level resilience as a part of being trauma-informed as organizations. And there are all kinds of workplace supports. I've just listed some of them that people have talked to me about as things that have really worked, as that they've put in place as we've been working together on trauma-informed approaches. So resilience training, trauma-informed supervision, there's a lot written about what it looks like to do trauma-informed supervision, peer support models, having staffing models where people have a bit of balance, and they're not only first responders, they also have, you know, other aspects to their work, so that it's a bit more balanced than, you know, always frontline, etc. Lots of people thinking about how does their organization do, you know, lunches together on Fridays, or do, you know, group yoga or meditation or workouts or walks or whatever. So I feel like people have really started to think more consciously about this. Just got a couple more minutes, so I'll just mention, I think one of the other strategies about being trauma-informed at the organizational level is really communicating about being trauma-informed. And here's some examples of how people have gone about it. The addictions folks in BC created these long posters that tried to signal to people coming into addiction services that people can and do heal from trauma. So they were trying to signal that they understand that trauma is in play, and that, you know, people can talk about that here. The blue one here is a pamphlet that the YWCA created in the course of that project I mentioned before, which names their commitment to trauma-informed practice as an organization. And they created that for their staff and for all the partners, the employers who take women who've been through the employment programs, etc., to really help everybody understand what it is to be trauma-informed and how important it is. The green thing is a beautiful thing that CAMH in Toronto created way back in the 90s that uses plain language to describe trauma that can sometimes be helpful as people are talking about it. And with clients, and finally, this child one on this side is from BC Children's Hospital. I worked with them on a project where they tried to signal to the families that were bringing in children that they were enacting trauma-informed practice without using the word trauma, but using the words of the principles that we do honor choice and collaboration and really want people to be involved in decisions about their care. So I think that is another important way of being trauma-informed at the organizational level, is making a commitment to it and conveying that to the people you work with and your partners. There's lots of help, and I've put these in the list to go along the way, about to go out to you afterwards, about checklists and you know, organizational audits and assessments where you can ask, they offer key questions you can ask yourself as an organization about how you're enacting trauma-informed practice in these areas, like hiring processes, supervision, your policies and procedures like debriefing, et cetera, et cetera. And they're really positive. They just, you know, say, where are we at now? Where might we go? So just to sum up, I just wanted to say that I think being trauma-informed is a core organizational approach, which really needs to be linked to other core practices, a couple of which I've mentioned here. And we did a project at the Center of Excellence during COVID, where we looked at, you know, how mental health, violence, and substance use concerns were already prominent in you know, as people were isolated and trying to do their best. And we looked for some of the common principles for practice and policy that the mental health, the substance use, and the violence field were all trying to bring into their work. And really noticed that a lot of people were taking this on, of trying to integrate these important approaches. And I think, it just gives me such hope to think about all of you working on mental health promotion as kind of joining up in this effort. So really like it if you take away today, or you ask me questions now that really, promote reflection for your organization about how you're using the principles with service users, how your organization is, expanding in its work towards being trauma-informed. What are the entry points for you in your organization? And most particularly, I guess, really like to think that people are advancing training and coaching and mentoring and debriefing for all the people who work for your organization. So we're all best equipped to be able to do this work. So I'll turn it over to you to guide me in questions that are coming up, if any have.
Wonderful. Thanks, Dr. Poole, for this most insightful talk. We really appreciate both you talking about trauma-informed principles generally, but also organizational applicability for these principles. So thank you for sharing that talk. We are now in question period, and our chat is open if anyone would like to post questions in the chat. I see one about a copy of the PowerPoint. So yes, that will be available. And we also, as part of our hub practices, we always create an event brief. And so that is a summary of the presentation along with any relevant links. So you've shared some excellent resources, Dr. Poole, that I'm certainly going to take a dive into and explore further, both organizationally and also as an individual within an organization. So we have some wonderful comments, but some thank you for rich review and supportive comments, which are really helpful.
I think on the challenge part there, I think every organization has some kind of different challenges based on their readiness. But I think one of the things that I think is really interesting is if I go back to this, this idea, I think a lot of organizations have not necessarily really trusted that service users can tell them and give them advice about what is traumatizing for them, and how the ways in which things might change. And I have some organizations I've worked with, for instance, they've gathered a focus group of folks after they'd been through the service and just said, so when you first came in the door, what was your first reaction, and what do you think there's anything about the way we first greet you or engage you that we could be improved? And then when we asked you about whatever the issue was at the organization, we use this question: what do you think of that? Like, are there other ways that we might ask about what your needs are, etc.? So I just think it's kind of neat, because so often when we're thinking at the organizational level, we're forgetting that the service users could give us some really good advice if we, created the kinds of questions that are about organizational practice, not just did the client, get what they needed, but more to the way the agency was set up or whatever. So I think there's, you know, each organization has different challenges in thinking it through, but I think the involvement and the sort of democratizing of how do we have a trauma-informed approach is a really interesting one. And even on another level is in that sense of trauma-informed supervision. So within the parameters of what you need people to do in terms of their workload, how do, you know, we create a situation where people are heard and have a say, and then there's, you know, a collaborative thing created about what ultimately will be in the work plan that, you know, takes in the needs of the organization, but also really recognizes particular interests and needs of the worker. So lots of different places where it, you know, becomes a challenge for different organizations to think through.
Yeah, thanks for that response, because there are so many ways I think that individuals can make a difference in an organization, but also being able to think organizationally how those structures, the policies, exactly what you were mentioning, Dr. Poole, about the questions that are asked and opportunity for discussion. There's also a comment here from Aisha, just appreciating your approach around organizational and provider resilience to moving beyond promoting self-care. So I think we you know, have talked a lot about self-care, especially during the pandemic, but also extending, as Aisha says, to protective factors and to workplace supports. And those aspects are critical, I think, thinking longer term. So beyond the moment of, you know, I need to go for a walk right now, but yet thinking longer term in terms of the protective factors.
Yeah, and I really like what she says, or they say, about compassion, satisfaction, and moving towards this idea also about vicarious resilience, not only vicarious trauma. And it's, you know, it really fits about trauma-informed practice is that, you know, that we can focus on strengths and resilience. It's not that we're ignoring that there's trauma, but we're really, with the light touch that we're able to do, not as healers, but as organizations trying to, you know, help people benefit to the greatest degree that they can from our services, is to really focus on that idea of how can both service users and especially the workers really see growth and change and the importance of their work in doing this. And it just changes it from being, you know, I'm completely overloaded, to being able to see the kernel of growth and change in everyone we see as well. And the world seems so hard these days, trauma coming at us from so many directions, that I think taking that approach is just such a positive one.
Yes, I think we have time for one more question from Danielle, and her question is, given how common substance abuse can be among individuals with trauma, how is this taken into consideration when we think about trauma-informed care at the organizational level? Thanks for that, Danielle.
Yeah. I'm not quite sure what the tenor of your question is. I mean, I think if I take the example of the violence against women's services, the shelters or the transition houses, whatever word you use. For many years, they had policies that said, you can't come here if you have substance use problems. We deal with violence and we can't have any of that here. But over time, they've recognized, like that picture I showed of the many aspects of overlap amongst trauma, substance use, mental ill health, and violence against women, that by saying you can't have that here, they were denying the realities of most of the women who were coming to their door. They were asking them to be silent on that and to not show that part of themselves so that, you know, they felt more comfortable rather than the client feeling like it was understood who they were. So I think what we're saying at this point in time is that we need to be able to support as harmful to themselves, and, you know, really help recognize to people and acknowledge for people, like that big long thing in the addictions field did about, we can cope with you talking about trauma here, right?
Mhm.
I think it's that kind of thing about integrating and understanding that substance use is often used as a coping mechanism, and it's done for because people think it will benefit them. And what we need to be able to do is to help people balance and think critically about how's it helping and how's it taking away, and what other strategies are there that are mental health promotion strategies that could really be helpful. And you know, I think it's such an important area.
Yeah, great, great comments, and thank you for addressing those. There are additional comments in the chat, and I wish we had time to review them all. But
And I wish I had time to talk about resilience training. I totally understand what you mean there. And I love the work of Resma Menaken on embodiment of racism and whatever. I would love to go down that road too, but we don't have time.
I was going to say, that sounds like another webinar. I
It
think.
is. It's a whole other story and a really important one. I'm glad you raised it.
Great. I'm going to pass the screen over to Colleen McMillan now, just for our closing comments. So thank you so much, Dr. Poole.
Yeah, thank you, Alice. There are just so many pearls that one can take away from the last hour of, after listening to you, Dr. Poole. And for me, it was how intersectional trauma is and how we have to think of trauma on a multi-dimensional level, you know, in order to be really effective from a mental health promotion approach. I encourage others to share their own takeaways in the post webinar survey that will soon pop up for you to complete. So a very sincere thank you, Nancy, for sharing your wisdom and your experience with us this afternoon, your passion in making complex concept accessible, not just through understanding, but how to act proactively is inspiring. You have shaped the message about trauma and trauma-informed practice to be transferable to whatever organization we find ourselves working in, and how we can promote protective factors for not just ourselves, but for those that we serve. So a very sincere thank you, Dr. Poole.
That's great.
So I'm going to end with just 4 really, really short housekeeping items. Number 1, just to reflect some of the questions in the chat, the event brief and the link to the recording of Dr. Poole's presentation will be emailed to you. And in addition, it'll be placed on our KDE website. Renata will be posting the link for a very short post-webinar survey in the chat. And if we can kindly ask you to complete it, we would really appreciate that. Please know that you are invited to the KDE Hub Annual Symposium on February the 28th and March the 1st. If you haven't already registered, The link to register, if you have not done so, will be placed in the chat box by Eric. We have 2 incredible days planned that will look at building and sustaining momentum within the mental health promotion field, and we would love to see you there. And lastly, enjoy the rest of your morning or afternoon. And on behalf of the Hub, we look forward to seeing you very soon again. Take care.